everybody. I'm Victoria. I'm the EMIM fifth year and the CCM fellow. We're going to be talking about managing the surgical airway patient. I know this is not a very PEDS topic, but I think trachs are really important to know about. So that's what we're going to talk about today. So I just want to set the scene. Let's pretend we're in CCT. You have two patients that come in. One of them is a nursing home patient with a trach that fell out today. You find them in the hallway. They're breathing, they're holding their trach, but they're breathing out of their mouth, and they're telling you, put their finger over their stoma, and they're telling you that their trach was dislodged today while they were being suctioned about 5 hours ago. It was placed because they have a tongue cancer and they're preparing for radiation. And then you look at the actual trach and you see that the cuff is broken. And then about an hour later, you're sitting writing your notes, and then EMS brings a notification for a nursing home patient with a trach that's bleeding. And when the patient comes in, he's agitated, and you see that there's brisk bleeding coming from the trach. And then as you're trying to suction him, the bleeding starts to pick up. So why do we trach patients? It seems kind of morbid, and I always thought it was a little bit extreme. But in general, we trach patients because they have some chronic ventilation needs, maybe some upper airway obstruction from a mass or a tumor. Sometimes there'll be a post-operative laryngectomy patient, which is a different special population. Or other times, and more commonly, it's failure to protect their airway, like in our neuro patients or our ICU, like decompensated patients. Trachs are actually associated with a decreased length of stay in the ICU, increased patient comfort, and more rapid weaning from the vent. And ultimately, the goal is to make them back to normal. So usually a trach patient will get discharged to a long-term care facility. Eventually, they'll wean from the vent and then eventually get trach decannulation. When you look at the trach, this is the different parts of it. I don't know if you can see my mouse. But here's the plug or the cap. This goes over the outer cannula. Usually this has some other sort of speaking valve or a Passamere valve, if you've ever heard of that. And in the corner here, there's other pictures of the other accessories that could be capping the trach. This is the outer cannula with the faceplate here. This is where your trach ties will go. And in this case, this is a cuffed trach. And you can tell it's cuffed as well because it has a pilot balloon, which is similar to like an ET tube. Another feature is this inner cannula, which is super important to have in place because this inner cannula actually connects to your bag mask. You can't just connect the trach directly to it. You gotta have the inner cannula in place. So these are just some different types of trachs that you can have. The most common one, and especially right after a new trach, is going to be your cuffed with the balloon. So this is important because the cuff is sort of like our ET tube. It's going to prevent air leakage. But the problem is that if the cuff is up or it's inflated, the patient can't breathe around it. So if you occlude the stoma, that's it. They're going to be, they're not going to breathe. And then Chest Society actually recommends cuffed trachs because it allows for positive pressure ventilation if you need it. An uncuffed trach is what you see here. This is a little bit more comfortable. The patient has to have a cough reflex in order to prevent aspiration, and they're able to breathe around it. But you can't do mechanical ventilation with this type of trach because you'll have too much of an air leak. And then another type, which is a true weaning trach, is fenestrated. There's a fenestration window like right at the top part of it. This allows for air to pass this way, around, and then back up so that they can produce speech. This one usually has like a Passamere valve. And this one is like a true weaning trach. So some of the complications that we're familiar with or that we'll see a lot in the ER, and we're going to talk about in the next couple of slides, are trach obstructions, trach dislodgements, and the feared bleeding trach from a tracheoinnominate fistula. So in general, when you're thinking about trach patients, you want to treat all the trachs like an ET tube. It's pretty much the same thing, just in the neck and looks different. You want to focus on the ABCs. Most of these patients are going to be airway breathing problems, so they're the fastest deadly problems. So keep that in mind that you want to treat the patient in the recess bay, not the hallway, even though they may be triaged there initially. And then also always having end tidal, just like any ET tube, you want to have not just the pulse ox, but the end tidal as well. And also look at the tracheostomy. Don't be afraid of it. It's there, it's existing, but don't be afraid that it's going to dislodge or that it's different. The first time that you're touching and manipulating a trach should not be during like a tracheoinnominate fistula emergency, for example. You always want to have respiratory there, and you want to have maybe ENT or surgery as backup because they're typically difficult intubations. And then when in doubt, just have your oral intubation supplies ready because you should, for the majority of patients, unless there's an oropharyngeal mass or some other strange anatomy, you should be able to intubate from above if you need to. when we're talking about putting these patients on oxygen, you can put oxygen on their mouth if they're able to breathe from their mouth. You can also put a trach collar, or I'm sure you all have seen like a trach mask. You can also escalate to putting the trach patient on a vent if you need it. So super important, always determining the what, when, and why with trach patients, like what type of trach, what size, what complications they've had in the past, when was it placed or when did it fall out, and knowing why they have it is especially important. Like I said, if there's any oropharyngeal masses, that's going to have a lot of different management, especially when we're talking about a backup airway. And know their baseline respiratory support. Are they on oxygen, trach collar? Are they on the vent? Make sure you provide that for them when they come in. So the next couple of slides, we're going to talk about troubleshooting some common emergencies. One of them is going to be obstruction. This is gross, and you will see patients that have trachs that look like this. The typical like nursing home patient who may have brewing pneumonia or some other sort of infection can come in with an obstructed trach tube. This is actually a super common complication, and like I said, it's usually from thick secretions, because if you remember, your nasopharynx warms and thins the secretions, so the trach patients don't have that. So in general, what you're going to do is make sure that the patient goes on oxygen. You can put it on their face and at the trach site. Remove any caps or any accessory devices. Remove the inner cannula, and deflate the cuff so that they're at least able to breathe around the blocked airway. You want to suction down the trachea. So that's not just using your Yankauer, but you actually have like a flexible catheter that you hook up to your suction and suction everything out. And most of the time, this is effective at removing a mucus plug or anything that's obstructing it. If it's not effective or you can't pass the suction, then you need to plan to start replacing the trach. And if they're in distress, then you need to plan for your backup oral intubation. By the books, technically trachs older than 7 days can be replaced in the ER over a bougie or fiber optic scope. But you have to be really careful, especially with newer trachs, that you don't want to create a false lumen, which is very common. Having ENT and again, like anesthesia to back up would be very helpful. And again, if you can't unblock this and you want to plan for definitive airway, you just do it per standard procedure for oral intubation. And once you secure their airway, make sure you remove the trach, because now this is not really helping you with anything. So this is just a little algorithm that I like to think about. Remember your what, when, and whys, putting oxygen on them, putting them on the monitors, removing any devices that are on top, remove the inner cannula, deflate the cuff, and suction down. If it's a newer trach, if it's an older trach, then you can replace it in the ER. If it's newer, then you want to get a definitive airway. And if it's newer with an upper airway obstruction, this is a more scary situation. You definitely want to have backup for that. Other ones, decannulations, which we see super commonly in like our first patient in the case. These are important because you need to know when it was decannulated. They can reepithelialize really quickly. So you want to make sure that you reinsert it promptly. And they might need to be dilated, so you should have ENT there with you. So again, just ABCs, right? Placing the patient on the oxygen, assess the soma site if there's any infection or any false lumen from somebody maybe trying to replace it. That's important to know. And again, if it's an older trach, you can replace it in the ER over a bougie or the bronchoscope that we have in the Pyxis. And if it's younger trach, then you want to prepare to intubate them from above first. I think the scariest complication, and I think one of the scariest patients to see, is a bleeding trach. These can show as just a little bleed first, and then they can become really massive hemorrhage. So again, your ABCs are super important. Reverse any anticoagulation that the patient may be on. And if you see that there's some minimal bleeding and you might see some granulation tissue around the stoma, sometimes you can put some silver nitrite, but I probably wouldn't touch it because it usually is a sign of something else that's brewing. And especially if the trach is pulsating, do not touch it. Just call ENT. If you see any active hemorrhaging, like our second patient, you just want to start resuscitating them based on their blood pressure, resuscitate with blood, and reverse any anticoagulant that they might be on while you attempt to locate the bleeding source. Some maneuvers that may be helpful, but in the literature that I was reading about, that there's no real benefit to any of them. You can overinflate the trach cuff in an attempt to like tampen out the bleed from inside. And if you do find a bleed, just apply direct pressure. Specifically what's bleeding, if you see in this picture here, there's an artery that's being occluded here. This is your innominate artery. This is a direct branch off your aorta. So when you have a tracheoinnominate fistula, which is the scariest part about this, it's a direct connection from the aorta basically to the trach, so they can bleed pretty heavily. Again, always plan to intubate from above before it gets too messy. And then some of the literature was saying to have this is called the Utley maneuver. So when somebody's intubating from above, have the other person put like a hooking pressure to try to occlude the innominate artery against the sternum. So again, the tracheoinnominate fistulas, this is the thing you really need to rule out when you're assessing a bleeding trach patient. This can happen either in a new trach patient or a chronic patient, and it's when the trach cuff or the tip erodes into the innominate artery. Usually you see this with patients who have low placed airways, chronic steroid use, or any neck radiation that causes a lot of friable tissue. And it's going to present as a sentinel bleed within a week of a major hemorrhage. You diagnose it with a CT angio if the patient is stable enough. And it's a very high mortality. Even the surgery itself, which is the definitive management, has a 50% mortality rate. I think I was reading somewhere between like just 14% of patients survived. So keep an eye on that. And then this is kind of another algorithm to summarize how to manage a bleeding trach patient. Again, oxygen, figure out why, what and when they have their trach, and then look at the trach side to see if there's any obvious bleeding. If it's minimal bleeding and the patient is stable, you can get them to CT angio, but you should really have ENT and surgery at your backup. If it's a massive hemorrhage and they're unstable, of course, resuscitate them and have everybody at the backup. Just a side note on the special population post-laryngectomy patients. These are what we call like obligate neck breathers. They have no connection between their oral and their respiratory. Their larynx was actually surgically removed. So what's difficult or tricky about this is that you don't have that backup of oral intubation if something should go awry with their stoma site. So this one is also very tricky. You want to, again, make sure you have ENT because this is going to be usually from a difficult and weird surgical situation, usually from cancers and things like that. So back to our case, if you remember from the first patient who was talking to you, you look at the trach, you see that the cuff was broken, you see that it's a size 6 Shiley, and luckily you have this brand. So you page ENT, and while you wait, you put the patient in a monitored room, you get him on end tidal, and you get a 6.0 and a 5.0, so one size down. And then you have your glide scope as backup, but luckily ENT comes, they replace it over their scope, and then they see that it's in the right place, and the patient improves. The other case, luckily you work at a level 1 trauma center, so you could call level 1 for the bleeding trach, and you overhead page ENT. In the meantime, you're quick thinking, you grab a syringe and you overinflate the cuff, and you're able to briefly clear the lumen just in time for your senior resident to intubate them from above, secure an airway. But now the patient starts to decompensate and become unresponsive. But luckily they're ready for the OR, so your job's done, right? So just some pearls when we're talking about trach patients, again, to summarize. Always know the what, when, and whys. Focus on their ABCs. I know it might be a little disorienting and a little bit scary to see somebody with a tube in their neck and not really talking to you, but it's always about your airway, breathing, or circulation, always. Focusing on their oxygenation as well. If they're oxygenating well, you have some time. Load the boat early with all your consultants. Again, these are going to be difficult airways. Take bleeding seriously. Don't just think like, oh yeah, I see a little bit of bleeding on the outside, so it should be fine. Always remember about the tracheoinnominate fistulas. And again, get comfortable handling the trach site. You shouldn't be the first time like suctioning a trach during a tracheoinnominate fistula, for example. And then always think about trachs as just ET tubes in the neck, essentially. And these are some common pitfalls that some people fall into. One of the pitfalls is I didn't call surgery because I thought we could handle it. You should have a low threshold to load the boat with these patients. I thought that the trach was in the right place because the pulse ox was normal. Just because the pulse ox is normal doesn't necessarily mean it's in the right place. You should also always use end tidal. The bleeding was small and it stopped, so we discharged them. You should always rule out that there's not a tracheoinnominate fistula occurring. And we cleaned the mucus plug, and then the patient became better, so we discharged them. Always consider why they mucus plugged. Is this an underlying infectious process or something else that sort of destabilized the stable trach patient?